All right, sex and gender students, welcome back to week number 3, where we're going to be diving into chapter 4. And this is going to be the biological foundations of sex and gender, because ultimately the sex we are born at birth occurs due to hormones that make our fetal tissue change to develop external sex organs that has what we are assigned at birth definitive. And there are a number of ways that frankly doesn't go as planned that can contribute to intersex and other sex conditions associated with chromosomal changes. So let's dive in and see how this can affect sex development and ultimately gender identification. So for chapter 4, we have a number of things we have to cover. First, we have to discriminate between biological systems that differentiate human and females and males. We have to recognize the endocrine system's role in producing hormones and the effect on sex differences and development. 3, we need to understand chromosomal and hormonal influences in prenatal development. 4, differentiate prenatal and congenital chromosomal and or hormonal abnormalities that affect sex and gender. 5, describe the process of puberty development for males and females. 6, consider how hormones continue to influence females and males throughout their lifespan. And 7, interpret the role of sex differences in brain development and function. There's a lot of things this chapter is going to go through and go over so that we are best able to care for people in general. So let's start off with our endocrine system and hormone production. So first and foremost, sex refers to the first and foremost, sex refers to the biological distinction or categorization between females and males. Like other animals, we display sexual dimorphism, which is physical size and appearance differences between the sexes. However, the biological determinations of sex is more complicated than originally thought, and the hormones and other factors that we have discovered can affect our gender as well as our sex. When it comes to the endocrine system, this consists of a series of endocrine glands that are found throughout the body. Endocrine glands release and circulate hormones, which are chemical substances that control or regulate physiological responses such as growth, reproduction, and metabolism, allowing for regulation of various functions. Part of the endocrine system includes the gonads, which are reproductive organs that produce the steroid hormones that are necessary for reproductive development. Steroid hormones produced by the gonads promote sexual development during the prenatal period and in puberty. And our gonadal tissue consists of our ovaries, our testes, and our androgenic hormones. Now, androgenic hormones are the steroid hormone that occurs predominantly in males, but also occurs in women just in lower levels traditionally. Ovaries are the female gonads. They produce the female reproductive cell and steroid hormones. Estrogen, the primary female steroid hormone, affects the development and regulation of female reproductive system and secondary sex characteristics. Progesterone is an androgenic hormone that prepares and plays a role in maintaining a pregnancy. The testes, which are the male gonads, produce the male reproductive cell and the hormone testosterone, the primary male steroid hormone that promotes and regulates sex development in men. Males and females produce both and all types of steroid hormones listed here, but it's in varying levels, which is what creates the differences. The endocrine system includes two important brain structures: the hypothalamus, which controls the release of hormones from the pituitary gland, and the pituitary gland, which is the master gland, and releases of various kinds of hormones, including oxytocin. Oxytocin is the feel-good hormone that is released at the beginning of a relationship where you have those lovey-dovey rose-colored glasses feelings. It's also released right after birth, again, to kind of mask the pain of birth to the individual that has just delivered the baby and allows them to better bond with their child because it's all warm, gooey, and lovey. It's the warm, gooey, lovey feeling. Now, the hypothalamus resides deep within the middle of the brain and maintains all these balances by controlling the release of hormones from the pituitary gland. So, this hypothalamus is kind of like the switchboard that tells the pituitary gland, make this, don't make that, do this, do that. And the pituitary gland is the gland that just secretes all the hormones based on what the hypothalamus is telling it. Now, this is just an image of all the components of the endocrine system. So way up at the top of our brain stem, we have our hypothalamus and our pituitary gland and pineal gland. Then in the neck, we have our thyroid gland and our parathyroid gland. On the heart, we have the thymus, and the thymus is predominantly only active in children. It's part of the growth hormone cycle. In the middle of our abdomen, we have our adrenal glands and our pancreas. And then finally, we have our ovaries and testes in the groin region. Now, sex development really begins at that chromosomal level. Chromosomal influences on prenatal sex development begins when sperm meets ovum. In a typical embryo, the 23rd pair of chromosomes determines the fetal sex. This is the X and the Y. This will not affect the development of the fetus till about 7 weeks of gestation. This is when differentiation begins and the internal structures start to form external genitalia. Again, sexual development begins at that chromosomal level. If you have two X chromosomes, this typically will produce a female. And if you have an X and a Y chromosome, this typically will produce a male. These are the only distinguishing factors for sex until the 7th week of development. Up to this point, the gonads are undifferentiated, and the Wolfram ducts from the potential have the Wolfram ducts in the fetus have the potential to develop into the male gonads, while the Mullerian ducts have the potential to develop in the female gonads. The embryo has both until hormone production begins. So at week 7, they appear differences in the genitalia. Internal genitalia are all the internal reproductive structures that distinguish between the sexes. External genitalia are the external visible reproductive organs that distinguish between the sexes. Differentiation depends on the presence or absence of testosterone. If testosterone is present, the Wolfram systems develop. If testosterone is absent, the Mullerian system develops, and this is the process called sexual differentiation. Historically, it was thought that sex determination was based only off the presence of a Y chromosome. This thought changed with Karanke et al. In 2007 and suggested there are more than one autosomal chromosome that influences sex determination. So here is a 5 to 6 week old embryo. Everything is very ambiguous. Now, between the weeks of 6 and 8, all fetus have the same structures. By week 9, sexual differentiation is apparent. Most fetus will be distinctively male or female by the end of week 12. Week 12 is when all of the sex differentiation has been completed. Now, here's an image that shows normal sexual development. So, in our first image there, as you can see at 6 weeks, it's pretty ambiguous. By week 10, we're starting to see the change in the developing glands and the closing and moving of the urethral groove that then will become the female a vaginal orifice and a separate opening for the urethral orifice. Then 12 weeks is when we have the complete differentiation where we see our traditional male appearance of phallus and testes with scrotum, and our traditional female with vaginal orifice and labia. Here's the thing. As you can see, in that 8 to 12-week period, some individuals do not realize they're pregnant yet. So there are a number of ways that this can frankly go awry and develop indistinct external genitalia, which would lead to a intersex development. And even if everything goes perfectly, there can be chromosomal abnormalities. Now, chromosomal abnormalities can affect the sex differentiation process. Now, chromosomal abnormalities, although rare, can occur when there are extra or missing chromosomes. And the impact of these conditions tend to be multifaceted, not just affecting internal and external genitalia development. Chromosomal abnormalities can also impact general physical and intellectual growth and development. So the first one we're going to talk about is that Turner syndrome. And this is where there is only one X chromosome. And Turner syndrome is a chromosomal condition that occurs before or at conception. And again, this is where there is complete or partial absence of that second chromosome. So they are an X0. It is a fairly rare condition, and females with Turner syndrome tend to be shorter and may not experience puberty. And only a low percentage are able to conceive as adults. And they can have very high risk pregnancies due to this. Our next condition is triple X syndrome or trisomy X. This is where there are 3X chromosomes. And symptoms vary widely. And the only consistent symptom found within this syndrome is very tall stature. Now, Klinefelter syndrome is a condition in males where there is an extra X chromosome. So this is an XXY. The most common symptom for these individuals is infertility. Other symptoms include tall stature, small testes, sexual problems, less pubic hair, abnormal body proportions, and increased chest size called gynecomastia. So where they actually have some breast development in a male individual. And specifically with Turner syndrome and Klinefelter and triple X, none of these are really diagnosed necessarily in a young child until they reach adulthood, until they're trying to have a child of their own and undergo testing, because the symptoms are so indiscriminate. And then our last one is 47, which is an XYY. And this is another syndrome that affects males. Males with this syndrome are at increased risk at learning disabilities and delayed development. Margery et al. In 2014 noted that this condition is associated with autism. They also noted that research has not focused on the role of the Y chromosome. And then Vistak et al. In 2009 noted the high rate of boys with 47 XYY have symptoms of ADHD that interfere with academic performance and then may lead to increased aggression. So these are ways that the XX and XY chromosome binary is actually shown to be very not binary, as there are 4 viable combinations of X's and Y within the chromosome that lead to a viable birth and pregnancy. Now, for our first controversial issue of this topic is the discussion of too male to compete as a woman. And I'm going to try to keep this very, very short because this is a rant of mine and something that I speak on aggressively within the sports chiropractic realm, because what this is talking about is an Indian athlete, a sprinter named Dutee Chand, And in 2014, she was banned from competing in the Commonwealth Games by Sports Authority in India because of her androgen levels. So her testosterone levels tested too high for her to compete as a female, although she was born biologically female. And she has a condition that causes her to have an increased testosterone level, which has led to them being declared she's unfair to compete. There's also another sprinter, this one from South Africa, Caster Semenya, that has the same condition, has excessive testosterone, and every time she competes, because she does so well and consistently wins, they want to ban her. Here's the thing. One, I want you to give your opinion on this, and then I will provide my opinion in the forum because I don't want to influence you. But this has led to a considerable number of discussions within the International Olympic Committee and recommendations for how these athletes should be handled when competing in their birth sex within their gender. So they were born female and now they may not be allowed to compete as a woman. So I'm going to leave it at that because otherwise I'm going to start ranting, but I would love to hear your guys' opinions. So if I'm biased, I want you to do this forum most, but you can choose whichever one you agree with for giving an answer. And my thought process on this will be provided in the forum. Now, when it comes to this differentiation, we then have our hormonal abnormalities. Over and under exposure to androgens can also have major impact on the development of an individual. Congenital adrenal hyperplasia is a disorder of the adrenal cortex, which is part of the adrenal gland that produces steroid hormones and mineralocorticoid steroids. And this congenital adrenal hyperplasia occurs in 1 in 15,000 births worldwide. The most common version of a congenital adrenal hyperplasia is deficiency of 21 hydrolase, which results in an increase in adrenal androgen and affects the body's ability to retain sodium, which can be extremely life-threatening. The external system of congenital adrenal hyperplasia depends on the chromosomal sex of the fetus. Often, females with congenital adrenal hyperplasia have ambiguous external genitalia, which can be corrected through surgery. Callens et al. In 2012 suggests that surgery is controversial because of the potential negative physical and psychosexual effects. Merck et al. In 2005 suggests that surgery should be done between the ages of 2 and 6 months by a multidisciplinary team with experience. Birnbaum in 2006 found that females with congenital adrenal hyperplasia have a higher rate of gender dysphoria, but this does not correlate with the most prenatal androgenic excess. Males experiencing congenital adrenal hyperplasia typically do not have symptoms at birth, but may experience an earlier onset puberty and a shortness in stature. Now, androgen insensitivity syndrome is a syndrome where genetic males are unaffected or unresponsive to androgenic hormones. The external sexual characteristics resemble those of females, and their internal genitalia are those of males. This syndrome is usually not discovered until puberty or during fertility challenges. Individuals are reared as girls and are considered intersexed. So let's remember sexual differentiation of a fetus genitals take place in the first 2 months of pregnancy. Again, based on the presence or absence of testosterone. Brain development occurs in the second half of pregnancy, during which male fetuses experience testosterone levels that are 10 times higher than female fetuses. So intersexuality is a condition where an individual either possesses sexual anatomy that is ambiguous or their external genitalia do not match their internal sex organs. Hermaphroditism is a rare form of intersexuality where individuals have testicular and ovarian tissue, either as separate organs or combined in one organ. According to Alderson et al. In 2004, the goal for those who have sexual development disorders is to encourage adjustment and the promotion of clear gender identity. Drop et al. In 1998 found that patients with partial androgen insensitivity syndrome experience depression and sexual problems and gender identity problems, but counseling can help these individuals. Schwab et al. In 2009 suggests that understanding hormones and the genetics may help us understand more about gender and sex, since hormones early in prenatal development cause genital development, but brain development mainly occurs later. There may be reasons for gender and sex to be mismatched. We are slowly discovering that gender and sex are complicated and that many individuals report being non binary, which is where they have both female and male gender characteristics, or have neither, or don't identify with one of the gender binary. Now, our next controversial is the infamous case of John/Joan. And this is the story of David Ramir. And really, this is often referred to in the context of an intersex surgery gone wrong, but it ultimately was a circumcision gone wrong, where during the circumcision, they actually amputated his phallus, and then he had sexual assignment surgery to become a girl and was raised as a little girl named Brenda. Now, for a deep dive into this case, I've actually included an entire documentary walking through the entire thing so that you can, one, actually hear some recordings from him. David struggled with severe depression and had attempted suicide a couple of times in his 20s. So had significant mental health issues due to the conflict of being raised a girl, knowing something was wrong, and then having to be told later in life that, well, actually, here's what happened. You were born a little boy, and we had to raise you differently because of a medical kerfuffle. So now that we've kind of covered all the fetal development of sex and gender and how the hormones affect the fetus, let's start talking about how the hormones affect us in puberty. Both primary and secondary sex characteristics are affected in puberty. Primary sex characteristics are caused by the maturation of internal genitalia and reproductive organs. Secondary sexual characteristics are the external changes that indicate sexual maturation has occurred. This is things such as pubic hair. For females, they typically go through a prepubescent growth spurt first. They experience the second characteristics of breast development, a new distribution of fat cells, and a widening of the hips. Primary characteristics are the growth of the uterus and the beginning of maturation. For males, secondary characteristics are the growth of the larynx and facial hair growth, descent and growth of the testicles, growth of the penis, and muscle development. Primary characteristics are the production and expulsion of sperm during ejaculation. So here is a Venn diagram of primary and secondary sexual characteristics, how they differ, and how they are ultimately similar. Now, that is how it affects us. So we have our fetal development, we have our puberty. Now let's talk about how hormones frankly mess with us every single day of our life. And really, hormone differences between the sexes are fluid and change throughout the lifetime. The first place hormones affect an individual in creating differences of sex is that prenatal development period and again at puberty. But hormones will affect us all the time, every day. For our first hormone we're going to talk about, that is testosterone. So this is an androgen-like hormone. The effects on the brain has been a subject of study for many, many years and still is not well understood. But there are some significant ethical dilemmas with understanding how testosterone affects fetal development in utero, because we don't like to do research on fetuses. So we can't really determine the differences. All we do know is the clarification that during sex differentiation, if there's testosterone present, a more male traditional genitalia will form. And then later in pregnancy, when brain development is going on, again, if high testosterone is there, the thought is that a more masculine brain will form, but we're not 100% sure on this. Now, prenatal exposure to testosterone in humans, again, not well studied. One study did look at testosterone levels during routine amniocentesis during pregnancy. So this is where they stick a large needle and they suck out some of the prenatal fluid and do some testing on it. What Hines et al. In 2002 found was increased testosterone exposure during pregnancy was suggestive of more masculine gender role behavior after controlling for environmental factors in females. But none of that relationship was discovered in males. Another study used a similar method with amniocentesis. Both boys and girls were exposed to elevated testosterone in utero, demonstrated higher male typical scores on gender assessment. And this was a study done in 2009. Digit analysis is also linked with prenatal testosterone exposure, and this was Wacker et al. In 2013. And lower digit ratio is linked with higher testosterone levels, and this correlated with higher levels of impulse sensation seeking behavior. What we're talking about with digits is this, that the closer your ring and pointer finger are in heights indicates a higher level of testosterone in utero. And frankly, on my hand, they are completely equal. So as you can see here, if I put my hand up, my ring and pointer finger are almost equal, and they are equal on both hands. Now, I don't find this overly surprising because I have polycystic ovarian syndrome, which means I have higher than normal level testosterone inherently. Yay. Now, in adulthood, testosterone is linked traditionally with aggressive tendencies and violent behavior. Cortisol may also play a role in these findings. Horn et al. In 2014 put forth that postulate. Then, Mastrapri et al. In 2010 found that social factors contributed to differences in testosterone levels. Higher testosterone and cortisol levels were found in men who are single, and married men have significantly lower levels than a single or divorced man. Now, caution must be taken with each of these studies, as environmental factors could have contributed to these findings. Now, our next hormone we're going to talk about are our traditional, more women-based, which is our estrogen and progesterone. These hormones contribute to the premenstrual syndrome and premenstrual dysphoric disorders, also known as PMS. So this premenstrual syndrome is the physical and emotional changes that some individuals experience 1 to 2 weeks prior to menstruation. Premenstrual dysphoric disorder is a more severe version of PMS and can be absolutely debilitating, leading to this overall disruption into normal life. And what they found is that 91% of women reported some form of PMS symptom, but only 10% of those actually qualified for having a true PMS disorder. And then 3% fulfilled the complete criteria for PMDD. And this thing can be applied to a common myth that majority of women experience PMS. This is perpetuated in media, so TV or magazine ads or any family sitcom with a stressed out mom. It certainly seems to be true. And that's the key operative word, seems. I mean, how often do you see, or even in our current cultural today, when we see someone that's having a bad day that we know is a menstruating person and they're upset or frustrated, we go, oh, are you PMSing? Oh, they must be on their cycle. It's been a stereotype perpetuated by media and culture that research does not support is as common of an issue as previously perceived. So, our next hormone is our oxytocin. This is made in the brain and is secreted by the pituitary gland. It serves as a messenger to affect female organs of the uterus and breast for childbirth and lactation. And although it seems to be primarily a female hormone, it also affects male as well. Research on romantic couples, which was done by Schneiderman et al. In 2012, found that oxytocin levels were higher for men and in women in relationships compared to singles. Hormone levels were associated with reciprocal behavior and whether couples were still together in a 6-month follow-up. So again, oxytocin is the warm, fuzzy, lovey-dovey hormone that makes you have rose-colored glasses. Those are our hormones. Before we dive into how our brain makes these hormones go through our body, we have to do a quick little baby review of our nervous system. Because if we don't understand how the nervous system affects us or how it controls us, we really can't start applying hormones to us. So remember, the nervous system allows the transmission of signals both through the body to the body, and it allows that overall communication. Our nervous system is divided into two main categories, our central nervous system and our peripheral nervous system. The central nervous system is the brain and the spinal column, and the peripheral nervous system is everything else outside that area. Now, the peripheral nervous system is divided into three things. One is our autonomic system, which is our autopilot things such digestion. We have our sympathetic nervous system, which is our fight, flight, run away, or our parasympathetic system, which is our rest. So right here, we have an image that kind of shows the anatomy of part of our central nervous system, which is our brain and all the different aspects. So predominantly what we've been talking about today is our hypothalamus, which we have our anterior hypothalamus, which comes into this area here. We then have our spinal cord coming down here. They do not have our pituitary glands, but that's going to be in this area as well, very much in the middle, let's say, lizard brain area. Now, we have to talk about the sex differences and similarities in the brain. Keenan et al. In 2012 found that male brains are larger overall, but regional differences disappear when considering whole brain volume. Brain size used to be an indicator of a female intellectual inferiority. But considering overall body size differences, the differences in brain size are minimal to null. So basically, they started just by looking at individual brains and saying, look, this man's brain weighs more than this female's brain. But then when they took into account the fact that you might have a 6'4" male and a 5'4" woman, they calculated that the differences were negligible once you accounted for the dimorphism of our sexes based on size. Now, researchers have focused on the cortical thickness, which is the cortex, is the gray matter covering the brain. Swell et al. In 2007 found that women had thicker cortices in the right inferior partial and posterior temporal regions. Now, the temporal lobes sit right behind the ears and are the second largest lobe in the brain. They are most commonly associated with the processing of auditory information and the encoding of that memory. So this would imply that women's brains could be better at auditory processing. Male brains were slightly larger than female brains in all locations, but most prominently in the frontal and occipital poles bilaterally. Now, the frontal part of the brain is part of the cerebral cortex, and it is important for voluntary movements, expressive language, and for managing higher level executive function. Now, the occipital lobe is located at the back of the brain and predominantly used for visual processing. This could indicate that on the more competitive hunter gatherer scale, the male brain was designed to be better at processing information quickly to determine safe, not safe, food, not food, in the hunting perspective. But again, we have to be careful how we interpret this finding because we fully don't understand how the brain functions, and we all know individuals within each gender that do not exactly fit this paradigm. Gong et al. In 2009 found that women showed greater overall cortical connectivity and a more efficient underlying organization of cortical networks. The brain region that has received the most attention is the corpus callosum. The corpus callosum is a thick section of neural fibers that connect the two hemispheres of the brain. Lutters et al. In 2014 found the corpus callosum was consistently thicker in males than in females when matched for overall brain size. Now, the main function of the corpus callosum is the communication between the two hemispheres. And that is all we know exactly, but it is hypothesized to play a primary role cognition. Emerging evidence suggests that a weakened integrity of the corpus callosum contributes to the decline in cognitive function in aging adults, which has huge implications when comparing the different genders and seeing that males traditionally have a larger corpus callosum. Keenan, again in 2012, found significant sex differences in the white matter or myelination of the corpus callosum and the cerebellum. Women showed an increase in directional dependence of diffusion in the corpus callosum, and males displayed this in the cerebellum. This finding suggests that these areas are more heavily myelinated and may explain the differences in motor and coordination in men, aka cerebellum, and the integration of information in women, the corpus callosum part of the brain. Now, hippocampal differences have been studied, and Pearson et al. In 2014 found that men have significant overall total cranial volume, but women have larger posterior hippocampus. Hippocampus size is related to the function of the parietal lobe and the prefrontal cortex in men and the temporal lobe function in women, which is a lot of brain things. And here's the thing. When it comes to understanding what all these different aspects of the brain and how this could play into personality or overall thinking and how it all relates, I'm going to let you in on a little secret. We don't fully understand it. We just don't. Every time we try to make a statement about how what part of the brain does what, something happens to prove that thought process wrong. The brain is still the mysterious nut that we have not fully cracked the understanding of, because still to this day, we do not understand how this mech suit that our conscious lives in functions and why each mech suit comes with a different personality. We don't understand that interconnection. So, although frustrating, and the last part, a little daunting when you're going through each individual segment of that brain, it's important to understand that in those research points, we're trying to find those differences. Think back to chapter 2. In those research studies, they are hunting, they are trying to find the differences between male and female brains. And ultimately, they may mean nothing. And if we did a study where we looked at a large enough population of maybe looking at transgender, non-binary brains, we may find that specifically for sex at birth, there isn't a difference between the brains of male and female sexes. But that's research that hasn't been done yet. So I hope chapter 4 was enlightening to how biological processes in fetal development, in puberty, and through our life of hormones and how that can affect our development as the gender person we are today. Make sure you listen to Chapter 5's lecture, which will be on gender development. So, the actual, how does all this come together to make the people we see? Tune in.